wabarakatuh. Good afternoon, everyone. And thanks all attendees for joining this webinar. And I would like to thank Giving Back to Pharmacy in Pakistan for organizing such a beautiful series of the webinar, especially this one, which is about the hot topic, Oncology Stewardship Program. I would like to first introduce myself and my panelists for the webinar today. My name is Mansoor Khan, and I'm working as a senior oncology clinical pharmacist covering adult oncology, hematology, bone marrow transplant, and palliative care medicine in one of the tertiary care hospitals in Saudi Arabia. And before that, I've been working as a senior clinical pharmacist in Shaukat Khanum Cancer Hospital and Research Center located in Lahore. And I have with me my first panelist, Dr. Ehsan Elahi. He's the lead clinical pharmacist in adult oncology, hematology, and bone marrow transplant at Shaukat Khanum Cancer Hospital and Research Center. Our third panelist is Dr. Zishan Ahmed Khatak, who is working as a clinical pharmacist in oncology, hematology, bone marrow transplant in Shifa National Hospital, Islamabad. Our fourth panelist is Dr. Sumaya Shakib, senior pharmacist, pediatric oncology in this hospital, Karachi. And our fifth panelist is from Khan University Hospital, and she is Dr. Anam Fatima. She is team lead oncology pharmacy. So I'll share my presentation with you. I think my presentation is already being shared. Can you see my presentation?
No, not yet, Dr. Mansoor.
Okay, I thought I shared it before. Just a second. Can you see it now?
It is visible. If you want to put it in slideshow mode, please.
Sure. Thank you. So the way we're going to proceed with this webinar, we will have first a presentation in order to have an idea about Oncology Stewardship Program first, and then we will have the panel discussion, how can we implement Oncology Stewardship Program in Pakistan. I must acknowledge Giving Back to Pharmacy in Pakistan for organizing a series of the webinars, and particularly this webinar, whose vision is to empower pharmacists for better healthcare. And those who know Antimicrobial Stewardship Program, you know that one of the key stakeholders in establishment of the Antimicrobial Stewardship Program were actually ID clinical pharmacists and pharmacists beside the ID physicians. So we have to replicate the same kind of concept when we are going to establish an Oncology Stewardship Program. So the key stakeholders in the Oncology Stewardship Program will be definitely oncology clinical pharmacists and oncology pharmacists alongside hematology and oncology physicians. And that's where this vision statement comes into a very significant note, that we have to empower pharmacists for better healthcare, and we need to empower our oncology pharmacists for establishment of Oncology Stewardship Program. But before empowering, we have to make them a competent pharmacist as well. So we will proceed with this vision and mission statement of the Giving Back to Pharmacy in Pakistan in order to proceed with Oncology Stewardship Program establishment in Pakistan, inshallah. I don't have any disclosure related to the contents of my presentation. So these are my objectives. As we said before, we'll try to understand the concept of the stewardship in oncology. And one of the key objectives of the Oncology Stewardship Program is to reduce the financial toxicity in resource-limited countries. You know very well the dire situation, economic situation in Pakistan, and cancer is not giving us any break. So we definitely have to treat cancer patients within our resources. So we definitely need to work out the ways how can we reduce the financial toxicities of these cancer patients. We need to analyze the situation and see what are the gaps and challenges in implementing Oncology Stewardship Program. And definitely there are lots of gaps, there are lots of challenges which we will discuss in the end of this presentation and during the panel discussion, inshallah. And we'll outline the role of the stewards, which is oncology physician and pharmacist, in activating this program, inshallah. So in order to understand oncology stewardship program, we have to understand the antimicrobial stewardship program. So antimicrobial stewardship program has been a standard of care in many tertiary care hospitals, in many hospitals, including many private hospitals in Pakistan, such as Shaukat Khanum Cancer Hospital, Khan University Hospital, Shifa National Hospital, and other hospitals in the country. So, and the benefits of the antimicrobial stewardship program had been quite obvious that it results in reduction of the resource utilization, reduces the cost, it improves the drug resistance, and it keeps a lot of option in the arsenal to treat infection and future line of infection. And we don't have such kind of program practically implemented in oncology worldwide. There are some hospitals in the United States who are actually working on it. There are some hospitals in Saudi Arabia and Middle East, and our hospital is the first one actually. We started working on it, and we proposed a model for oncology stewardship program, and we have kind of partially implemented in our hospital. But definitely there is a need to establish this kind of program in resource limited countries such as Pakistan, India, Bangladesh, and many other third world countries. Okay, there are three integral components of this oncology stewardship program, which is value, quality, and safety. And we have to design in such a way that we achieve all these three integral components. And one of the key value of oncology stewardship program is to reduce the financial toxicity, and we'll define what is the financial toxicity in a minute. And another value of this program is to improve and select and improve the cost-effective treatment options. So when we talk about the cost-effective treatment option, we definitely mean that this regimen is effective, safer, and cheaper. It's not only cheaper, and also we have to consider improving the quality of life of the patients. So what is a financial toxicity? So this is terminology which is used by many international societies. You go to different meetings in the United States, Europe, so they always touch upon financial toxicity. So financial toxicity is the distress or the hardship which is experienced by the patient and its caregivers, and that is resulting from the financial burden of the cancer treatment. And I'd like to share with you some of the statistics from the United States. I wish we have the statistics from our country so we can see our situation is much more poorer than the statistics from the United States. So according to this survey, in 2016, there had been 19.6 million cancer survivors in the United States, and 1.4% had been declared bankrupt, and 1.7 million, which represents 8.6%, had been reported making other financial sacrifices. And imagine United States have such a beautiful reimbursement system, insurance reimbursement system in the United States. And all the research and development in the cancer is actually been executed in the United States. So imagine our Pakistan economy and how many people must have been doing financial sacrifices. I think you can easily multiply this number with 10, and then you can see where we are standing. And I would like to also dissect the financial toxicity into two categories: objective financial toxicity and subjective financial toxicity. You know, the payment system in cancer care is very complex. It's multi-layer payment structure. So the patients are not only selling their own assets, and they're also selling the resources, pool resources of the other people within the same family. So what happens, the objective financial toxicity is basically the cost associated with the treatment. This could be the direct cost of the medication, or this could be costs associated with the travel and other related costs. But imagine in a country like Pakistan, we are living in a cultural society where usually one or two people are the sole breadwinner of the whole family. And imagine if this breadwinner is the cancer patient, then he's not able to go to job, so then will not be able to get his wages. So that could result in significant anxiety and discomfort for the whole family. And the people will start selling their resources. And not only this, they will they will be selling the pool resources of the other people, not in the direct family contact, but also they will try to borrow loan from others. So this is the thing that is really very significant. Imagine this definition and all this data is coming from the United States. There is no such data coming from Pakistan, a resource limited country, just Pakistan. And if we have some data from Pakistan, then you can see how dire is the situation in Pakistan. So we talked about multi-layered pyramid structure. So this is the most important slide of my presentation. So there are four important parameters that we need to establish in order to establish the Oncology Stewardship Program. I'll skip the point number 5. The first point is the cost-effective formulary management, including class reviews approach. So this is very important, and the first point, the most important point actually in establishing the Oncology Stewardship Program. And during our panel discussion, we will try to discuss how can we empower our clinical pharmacists to be integral part of the pharmacy and therapeutic committees so they can play their significant role in formulary management. And I'll share with you a couple of examples from Ministry of National Guard Health Affairs Saudi models. And if we can replicate this model in Pakistan, then we can play our significant role in PNT committee. The other thing is the most second point is very important point is the development and implementation of the clinical practice guidelines. You know, if you flash back your memories with establishment of the antimicrobial stewardship program, how did we develop antimicrobial stewardship program? You know that we first had the guidelines, clinical practice guidelines, and the drug use policies, and then we try to do some kind of audit mechanism in order to see how compliant we are with our guidelines. We need to do the same kind of mechanism in oncology stewardship program. We have to have the same kind of clinical practice guidelines in oncology, and the oncology clinical pharmacists, they have to play their due role in establishing these clinical practice guidelines and the drug use policies. And then we should do audit mechanism, periodic medication use evaluation in order to see whether we are compliant with the oncology stewardship program or not. We can set a target, for example, we set a target here as 80% or more than 80%. We should be adherent to our policies and the guideline. And if we are compliant with 80%, then we are doing our job very well. And the third most important thing, which is not being followed in many countries, including the developed countries such as the United States and Europe, which is the implementation of clinically meaningful outcomes in utilization of formulary and non-formulary oncology drugs. And I'll try to explain this with examples in the coming slides. The fourth important point is the implementation of the high-quality oncology generics and biosimilars, which can significantly reduce the healthcare spending and improve the financial toxicity of our cancer patient and cancer and their caregivers. So if we can implement these 4 points, then we can establish oncology stewardship program. And if we can implement 1 or 2 points, we can still be quite happy about it that we have partially implemented oncology stewardship program in our institutions. We have talked a lot about the role of oncology clinical pharmacists in the past series of webinars, as well as in giving back to pharmacy in Pakistan in 2 or 3 conferences. So I'm just taking you back just to summarize that we play a significant role in formulary management in developed countries, and we need to do the same kind of role in Pakistan. And for that, we need to empower our pharmacists to play their due role in formulary management. And before that, we have to be competent. A few days ago, somebody was telling me that in public sector, actually, the pharmacist is just signing the papers and they're not doing any professional skilled work. So they are not empowered. So the thing is that they are actually not technically competent to do that job. But if they are technically competent, then they can definitely be assigned these kind of tasks to execute in formulary management. And being oncology clinical pharmacists, we are attending multidisciplinary meetings, for example, rounds, tumor board meetings, and we definitely during round, we assess the patient and we recommend treatment options, chemotherapeutic option. And I personally and my team in my hospital, we recommend cost-effective treatment options, and these are highly appreciated by tumor board meetings and during the rounds. And we do definitely medication management, and we do participate in clinical practice guidelines, and we do a lot of medication use evaluation. And when it comes to oncology stewardship program, we have to do more and more medication use evaluation in order to see whether we are compliant with our oncology stewardship program or not. Around 20 to 30% of the time, I'm dealing with cost-effective treatment recommendation for the treatment of cancer. And about 70% of the time, I'm dealing with supportive care, for example, febrile neutropenia, infection treatment and prevention, chemotherapy-induced nausea, vomiting, and everybody knows our role is so significant in supportive care. And I'm sure our oncology clinical pharmacists, they are doing a great job in this particular role in Shogat Haram, in Shifa National, in Indus Hospital, Khan University Hospital, and other hospitals in Pakistan. And we probably try to do this kind of exercise in the public sector as well. It's a high time to involve pharmacists in the cost of care discussion. I'm sure Shogat Hanam is doing it. When I was there, we used to be involved in cost of care discussion, but actually we were kind of partially involved in cost of care discussion. But when I mean cost of care discussion, we mean here the cost effective treatment options. So we can tell the patient that which treatment is more cost effective for them. I think this is the role that we have not put ourselves into the shoes of this role. So probably we need to find ourselves in this role, and where we can be very transparent and very clear for the patients when it comes to the cost of care discussion, and we recommend cost-effective treatment option, and we take the responsibility for that. Now, I'll try to explain the cost-effective formulary management, why it has a significant impact on the Oncology Stewardship Program. We personally, in Ministry of National Guard Health Affairs, are integral part of Pharmacy and Therapeutic Committee. We have certain many subcommittees and major corporate PMT committee, as we are working in a corporate organization. So the clinical pharmacist, the committee is composing of around 50 to 60% of the clinical pharmacists in the corporate PMT committee. We do scientific and pharmacoeconomic evaluation of oncology drug, and we ourselves presented in the PMT committee, and it goes through very sort of stringent scientific discussion and pharmacoeconomic discussion, and then the voting takes place, and then the medication is approved to be added to formulary. We probably need to do the same kind of role in Pakistan, because this is the first step in establishing the Oncology Stewardship Program. So, for example, a chief executive officer had been asking us to reduce the healthcare expenditures in oncology by 100 million reals in 2018 and onward, and we have been able to achieve by our cost-effective formulary management. Not only this, the medication which are available in formulary, we have to use cost-effective alternatives for formulary medication. And the development of the clinical practice guideline and drug use policy, this is also a significant role. Being clinical pharmacist in PMT committee, he can play a very significant role in development of the clinical practice guidelines. We talked about medication use evaluation, and whenever there is a request for a new oncology medication, there are many other medications within the same chemical class or therapeutic class. So sometimes a medication which is used for one cancer, for example, renal cell carcinoma, and we're discussing nivolumab, for example. So not necessarily the other drug is from the same class, but actually if it's used for the same indication, then we can do therapeutic class review as well. So these kind of class reviews are very important, because these kind of class reviews, not only you will be able to select the medication which are more effective, but also you will be able to invite the competition between the industry that results in significant cost reduction. We do periodic oncology formulary review, and we do treatment de-escalation and treatment-free remission recommendation, which has saved millions and billions in our hospital. I'll share with you one of the examples and why medication use evaluation is important, and we should be doing medication use evaluation. And the trigger two for selecting the right medication use evaluation, it could be efficacy, it could be safety issues, it could be cost issues. So we found that we had been spending around 40 to 50 million reals on factor 7, which was being used as prophylaxis for hemophilia A and B, and for the treatment of the hemophilia A and B when they come with the bleeding. And we found that these patients, when they are receiving prophylaxis, despite receiving prophylaxis, they are coming to hospital with annual bleeding rate of about 25 per patient. So that means they are admitted in the hospital for the management of the bleeding for about 25 times. And each time they get admitted, we spend like half a million riyal on them. So that was very significant expenses on the stretched budget of the Ministry of National Guard Health Affairs. So we reviewed the alternatives, and one of the cost-effective alternative that we found was the FIBA. FIBA was approved for prevention and for the treatment of the bleeding in hemophilia A and B patients. And when we used FIBA, we reduced the expenditures by around 15 to 20 million. Not only this, we reduced the annual bleeding rate from 25 to somewhere zero. And at the same time, for the patients with those used to come for FIBA, they had to come to hospital 3 times per week for 2 hours infusion of FIBA. Then we found another agent, which is emicizumab. And this emicizumab is given weekly or every 2 weeks or every 4 weeks subcutaneously, and patient does not need to come to the hospital, and that can be given by the patient themselves. And by doing this kind of class review, this kind of medication use evaluation, we invited the competition between the industries, and emicizumab became even more cheaper than FIBA. So by doing this MUE, which triggered the therapeutic class review, we were able to come up with the right medication for this indication, which was able to not only reduce the expenditures by more than 20 million riyal per year, but also we were able to reduce the annual bleeding rate, the annual admissions of these patients from 25 to zero. And these patients and their caregiver, they were able to go back to their job and live normal life. And that's improved. That's example that I wanted to give you to improve the quality of life. So these kind of things, basically, if we can exercise in our country, that will improve patient care, that will reduce the financial toxicity. So here we have reduced not only the objective financial toxicity, which is direct reduction in the direct expenditure associated with medication, but also we have reduced subjective financial toxicity. The patient and patient's caregiver, they were able to go back to their business, they were able to go back to their job, get married, have children, and have the responsibility on their shoulder and execute their responsibilities. So by doing this, but this needs a lot of scientific competency, and this needs a lot of work to be done in our hospitals. So this is just an example. So there are many millions of other examples that we can do in our professional life in order to improve the quality of life of our patients, actually. There are many other examples. For example, nivolumab can be used weight-based, and you can save millions and billions. And I'll use a couple of other examples. And this example, inotuzumab over blinatumomab, I'm not sure whether these are available in Pakistan or not, but this just to give you an example, like inotuzumab is 3 times more cheaper than blinatumomab, 2 times more effective, and it can be given outpatient setting. You don't have to admit the patient, versus blinatumomab, you need to admit the patient over 28 days. So we use these kind of alternatives from the formulary management perspective, and the management and the higher administration, they have really, really admired and appreciated and acknowledged our role, and they're accepting anything from us that we offer to improve the patient care, reduce the financial toxicity, improve the quality of life of patients. We published one of the paper because we offer treatment-free remission. Chronic myeloid leukemia patient, they have to be treated with the tyrosine kinase inhibitor for a longer period of time, actually lifelong treatment. Those who are treating CML, they know that they have to be on imatinib, dasatinib, anatinib, or ponatinib for lifelong. So what we have seen, some published papers and attending international meetings, just ASH, American Society of Hematology meeting, and from our observation, we saw some people are offering, and also NCCN guideline offering some treatment-free remission. So we brought it here, and then I discussed it in the PNT committee, and then we said, okay, those patients who are in deep molecular response rates for more than 3 years, so we can offer them to go off therapy. And let's see how many of them are going to require therapy again. So we found around 92% of these patients, they are in treatment-free remission. So by doing this, we published this paper in one of the journal of hematology, and I was the supervisor of the study. And by doing this, we saved first 6 months 7.2 million riyals, and only 8% of the patient they had molecular relapse, and they resumed the tyrosine kinase inhibitor, and their molecular response is regained within few months. So we need to offer these kind of things in Pakistan to reduce the financial toxicity. Imagine even if 60 or 70% patient we can achieve TFR treatment-free remissions. We can save millions and billions in Pakistan. We did many cost-effective studies and published in peer-reviewed journals in the United States and European papers. So one of our paper was a 6 milligram fixed dose strategy, and we found we were able to achieve the primary outcome in more than 80% of patients, which was the normalization of uric acid at 24 hours using 6 milligram single fixed dose. And there was significant cost-saving benefit associated with that. Not only this, we are also doing 3 milligram fixed dose strategy. The FDA approved dose is 0.2 milligram per kg for 5 to 7 days. And this paper will be presented in HOPA, which is Hematology Oncology Pharmacy Assembly this year, next month in Boston, inshallah. We did some also cost effectiveness evaluation. For example, this gallium trial, which compared obinutuzumab versus rituximab based regimens for follicular lymphoma, and 3-year progression-free survival were not very different, 80% versus 73%, but the cost difference is almost 3 times. And if you imagine the biosimilar rituximab, then this cost difference would be 4 to 5 times. So we need to replicate these kind of things in Pakistan. The second point is the development and implementation of the clinical practice guideline, which is one of the most important part, you can say bread and butter of the Oncology Stewardship Program, is to have the clinical practice guideline, to have the right clinical practice guideline, to make sure that these clinical practice guideline and drug use policies are cost effective. And then we need to empower ourselves, our pharmacists, and we need to activate we need to have collaboration and our collaborative practice agreement between all the key stakeholders, which is pharmacists and physicians. And definitely we need to empower our pharmacists, and we need to have a due role to play in PNT committee and other multidisciplinary committees in order to have cost-effective guidelines. I'm sure Shaukat Khanam, Aga Khan, Shifa International Hospital, Indus, and other hospitals, they do have the guideline, but we really have to make sure that these guidelines are cost-effective guidelines. The third point is the implementation of the clinically meaningful outcomes in the utilization of the formulary and non-formulary drugs to avoid drugs with dismal clinical effectiveness. There are many solutions underway according to this position paper by American Society of Clinical Oncology published in 2017. One of the solutions is to have value-based outcomes, oncology stewardship team, ESCO value framework, development of the biosimilars, and many more. And ASCO published, JCO published one of the ASCO recommendation in 2014, and they came up with some of the clinically meaningful outcome for the first time, like 8-9 years ago. So they have mentioned here what is the current baseline median overall survival in 2014 for pancreatic cancer, lung cancer, breast cancer, and colon cancer. And they are saying if any intervention can improve the overall survival on the top of the current baseline median overall survival by 4 to 5 months, more than 3 months, I would say, that is considered clinically meaningful outcome. But if it is not showing any overall survival more than this, that is clinically not meaningful. There is ESMO magnitude of clinical benefit scale. You can review it later on. There is NCCN evidence block. There is which can dissect different regimens with regards to affordability. I'll show you example of clinically dismal outcomes. So regorafenib is used for third-line agent or treatment option in metastatic colorectal cancer in many countries, including Pakistan, I'm sure. So one of the landmark trial, which led to the approval of regorafenib for metastatic colorectal cancer, was the CORRECT trial. If you look at one of the outcome, which is the progression-free survival was 1.9 months with regorafenib, and it was 1.7 months with the best supportive care, which is only a few days difference between the regorafenib and the best supportive care. Look at the p-value, less than 0.0001. That tells you like it's statistically very significant, but clinically it is not significant. And in our experience, we have seen it does not improve the quality of life of patients. So it deteriorates the quality of life of patient, and financially it drains a lot of money in resource limited countries from poor patients who are not given the right perception about their treatment. So we did not approve regorafenib by playing our role in P&T committee. We did not approve regorafenib as either as a formulary medication or as a non-formulary medication for this indication. Have a look at regorafenib versus TAS-102. These are the two agents which can be used in third-line setting in metastatic colorectal cancer. So both have dismal outcome when it comes to progression-free survival. Only few days improvement in progression-free survival was seen in both RECOURSE trial as well as in CORRECT trial. So based on this, we did not approve monotherapy regorafenib and TAS-102 for this indication in our hospital. However, when you combine TAS-102 with bevacizumab in CTAS-4 phase 2 study, that improved the overall survival and progression-free survival significantly. Almost the PFS was doubled and overall survival was almost doubled. So we approved the combination of TAS-102 in combination with bevacizumab in third-line treatment option in metastatic colorectal cancer. Sorafenib is also used for hepatocellular carcinoma, although it's not the standard of care anymore. But the SHARP trial, which was this landmark trial for the approval of the sorafenib in HCC, was actually enrolled only Child-Pugh A patient. And in countries like Pakistan and also many other countries, patients usually present when the disease is advanced and they are in Child-Pugh B or C, where actually sorafenib was not tested. So in my experience, what I have seen that when sorafenib is used for Child-Pugh B and C, it does not improve the quality of life. It does not improve the progression-free survival. It does not improve the overall survival. It only decreases the quality of life. It only increases the hospital admission, thrombosis, neutropenia, infection, hand-foot syndrome, and financial toxicity. And even NICE guideline, they did not approve sorafenib as it was below. It was above the ICER threshold per collie, and Ministry of National Guard Health Affairs, we created guideline for sorafenib that we will use it only in Child-Pugh B and Child-Pugh A, and we will not use it for B and C, and that is saving around 4 million reals per year. But it's not only saving 4 million reals, we are also improving the quality of life of patients. Moving to the last point is implementation of the high quality oncology generics and biosimilar to reduce healthcare spending. Why do we need to integrate biosimilars into oncology practice? And a role of the oncology clinical pharmacist is very significant here. We know that the global market for biologics is increasing and it's expected to reach $310 billion by this year. And we speculated 3-4 years ago that if we can approve biosimilars, then we can invite the competition between the innovators and the biosimilar industry, and we can have very significant cost saving of about 30 to 50%, and that can result in expanded access of biological to cancer patients. We also published one paper a couple of days ago where we speculated that if we switch 4,000 patients from Neupogen to biosimilar filgrastim, we can generate an amount of revenue which is enough to treat early stage HER2-positive breast cancer, those who have residual tumor, with one of the state-of-art therapy, edotrastuzumab emtansine, which is also called TDM1, for 61 to 191 patients in Saudi Arabia. And one of these forecasts that we published in one of the American journal a few years ago, that if we do add trastuzumab, 3 blockbusters, trastuzumab, rituximab, and bevacizumab biosimilars, we will be able to generate a cost saving of about 30 million reals for Ministry of National Guard Health Affairs. And that time, the Roche people, they came to me, they printed the paper, they came to me, how can you say that? How can you say like, we will reduce 30%, the biosimilar company will reduce to 30%, and then the innovators will reduce 30% and we'll be able to enjoy 60% cost saving. I said, we will be able to do that. They said, we are Apple, we are Silicon Valley, nobody can break our monopoly, and we were able to break their monopoly, and we managed to bring the biosimilars of these 3 blockbusters, not in our country, not in our hospital only, but also in the whole country and in the whole regions. And that is saving billions of dollars for the Middle East. And that's going in compliance with the country's Saudi Arabian Vision 2030. And we need to do the same kind of replication in Pakistan. We published one paper in one of the US journal showing the cost-saving benefit of filgrastim. When we switched 77% of the neopogen to biosimilar filgrastim, we were able to generate 60 million real cost saving by this exercise. We have also published an institutional guide for formulary design of the biosimilars in hospital pharmacy, which is one of the peer-reviewed journal in the United States. And I think so we need to replicate these kind of guidelines for hospitals in Pakistan. Lastly, we were discussing among our group that we are physicians, hematology oncology physicians and other physicians. They have no trust in biosimilars and high quality generics. So that's the thing. It was the same perception of the biosimilar was existing in Saudi Arabia and the Middle East. So what we did, we had many conferences. We arranged many video conferences, hybrid conferences, and we try to educate people about biosimilars. And then what I did actually, I tried to involve oncology hematology physician as the stakeholder, take the responsibility of the biosimilar black blockbusters in oncology. And then they became the ambassador of the biosimilar. So that's how you can improve the perception. And the best way you can develop trust in biosimilars and have the reassurance on the quality and safety of the biosimilars to have the real world evidence. So one of my PGY2 resident, he did real world evidence on the use of biosimilar trastuzumab in early stage breast cancer, and I was the supervisor of this study. And it was a retrospective study, and IRB had approved it. The primary outcome was to assess pathological complete response of trastuzumab Kangenti in neoadjuvant setting of early breast cancer. And the secondary outcomes were the safety. So we were able to achieve primary outcome, which is pathological complete response in 82% of patients. That means when patients were taken to OR for surgery, there was no tumor left over. And imagine in the trials which we were comparing this study with, such as Neosphere and Trifina trial, they were able to achieve pathological complete response rates in 49 and 46%. We're not trying to prove here a point that biosimilar trastuzumab is better than its originator, but what we are trying to establish, the fact here is the biosimilarity of our biosimilar with the originator. We are not less than that. So this study has produced significant assurance to the stakeholders so they can comfortably use this drug in their patient, and they can, word travels from one place to another, and they can talk to other that biosimilar is as good as the innovator. Okay, and this study is still going on, and we are recruiting more patients. So we need to do, my colleagues in Pakistan, and I'll discuss with the panelists, we need to do these kind of studies in Pakistan in order to have the reassurance of our stakeholders and the confidence in the use of the biosimilars and high quality generics. So what are the, how can we implement Oncology Stewardship Program in Pakistan, and from where we can start? So first thing is we need to be competent. We need to educate ourselves, and we need to know our skills. And then we need to establish a multidisciplinary stewardship team to establish and run the program. We don't have to start this program in all the diseases at the same time. We can select one disease or few diseases and see those diseases are those regimens which are very expensive, and try to make sure that we use cost-effective use of the expensive regimens. The most important thing is to have the develop the clinical practice guideline and the pathways, and to do periodic MUEs in order to see whether we are in compliance with these guidelines or not. And we set a goal if we can achieve like 80%. Or in the beginning, if we can say if we can achieve like 50% of compliance, that's pretty much good job that we have achieved. Okay, I'll share with you some of the examples of Oncology Stewardship Program. For example, in HER2 positive breast cancer, although pertuzumab might not be available in Pakistan, but I'm just sharing with you examples. So in future, we can have a list of the oncology targeted therapies, and we can have the examples from Pakistan in order to tell people about the perception of this program, but I'm sharing with you examples from Saudi Arabia and from the United States model. For locally advanced breast cancer, HER2 positive, affinity trial evaluated a combination of pertuzumab plus trastuzumab versus trastuzumab in the adjuvant setting, and the primary outcome was invasive disease-free survival. And invasive disease-free survival was only 1% better with the combination of pertuzumab and trastuzumab versus trastuzumab monotherapy. But in the combination, for only 1% improvement in invasive disease-free survival, we have to spend half a million real extra per patient in Saudi Arabia for this very marginal risk reduction. So it's not cost effective. We did not approve it. And we recommend biosimilar of trastuzumab used alone in adjuvant setting is cost effective. In Hodgkin disease, many of our colleagues and panelists, they might know Echelon 1 trial, which evaluated the gold standard of care ABVD in Hodgkin disease versus brentuximab plus AVD in the first line setting. And the primary outcome was 2 years progression-free survival, which was marginally better with the brentuximab AVD, 5% improvement, but at the cost of 250 to 500,000 real per patient, which is not justifying this cost. And moreover, brentuximab can be used in second line setting after the patient relapse on ABVD, and then we can salvage them with brentuximab, bendamustine, and take them to autologous stem cell transplant. So we did not approve this first line indication, and we recommend ABVD over AVD plus brentuximab. What
Mansoor
are the
bhai,
challenges?
Assalamu alaikum. Just for the sake of time, just a reminder, we have only 15 minutes left.
Okay. So I think now we are moving to the panel discussion. So challenges faced in the interpretation of implementation of the Oncology Stewardship Program in Pakistan. So one of the first challenge, I would like to invite my panelists here. So one of the first challenges is the lack of national guidelines and consensus on the treatment of different cancer diseases. But actually one of the biggest challenges anticipated resistance from oncology-hematology physician for oncology stewardship program. And another challenge is that we don't have enough competent pharmacists who can actually be stakeholder in this. We definitely, they will be empowered, but before empowering them, we need to make sure that they are competent. And increasing number of cancer cases in Pakistan, and there are many drugs which are not available in Pakistan. So I would like to invite my panelists here to talk about these challenges. How can we implement this? So Dr. Ehsan Elahi from Shaukat Khanam Cancer Hospital, uh, how can you address these challenges in Pakistan? And also, you have to discuss like our role in PNT committee in drug use policies, as well as clinically meaningful outcomes and all those things. So how can we accept this challenge, address this challenge? Dr. Ehsan?
Thank you very much, sir. Masood. Am I audible?
Yes, yes.
So this was very well presented. This is basically the need of the hour, and how we offer the patient a cost-effective anti-cancer treatment to a patient suffering with the cancer. So basically, working in a resource-limited country like Pakistan, we have to face a lot of challenges. You very well explained here, just like uh, there is no, you can say there's no formal guideline or the formulary available to address the cancer treatments for the patient. But the main thing which I would definitely agree with you is that there is, you can say, a monopoly of the physician, or you can say there are the pharma companies who directly go to the physician and discuss with them about the availability, about the packages they are going to offer with the chemotherapy drugs. Yes, this is indeed a problem here in Pakistan. So this would definitely be overcome once the pharmacist is competent enough to discuss the cost effectiveness of the therapy with the physician. For that purpose, the pharmacist must be educated. He must be informed with the latest guidelines, with criterias, with recommendations, with international practices. This challenge can be overcome, but keeping in view the shortages as well. We have a recent episode of very scary shortage in Pakistan due to the economical crisis of Pakistan. and we were actually we were stocked out of doxorubicin. There were no doxorubicin available, and at times there were around 6 or 8 malignancies which were directly affected by the doxorubicin availability. So, in my point of view, this is basically, you can say, a cocktail of number of factors which need to be addressed. So first we must know what kind of resources we have in Pakistan, just like in the form of manpower, how many pharmacists we have, who will be directly involved in implementing this stewardship practice within their organization or the institute. Secondly, we will have to empower them. We will have to educate them. They must consider and they must focus and invest on themselves first, to educate themselves so that they could address the dilemma to the world. They could address the problem they are facing. They could address the challenges they are facing in their organization. And thirdly, after that, we will be definitely able to address this issue at the national level, that how we can have a better and affordable formulary drug even at the national level, so that we could have a same streamlined pattern of formulary drugs within the Pakistan. And we could have a task force to have this, or we could have a group of people who will have to perform this activity by dedication. So this is what I think is the 3 or 4 points that we must focus on it. And in addition to it, we must present certain statistics. Yes, definitely. Statistics basically lead to enable you to argue with someone at some point. We don't have a data available from Pakistan, but I agree, and I am very hopeful that a lot of my colleagues in SKM and in other organizations like in Shifa and Aghan, we are at somewhere partially implementing the oncology stewardship in our organizations, but we have to streamline it. We have to make it in a systematic way. So this is what I think in this.
Thanks a lot, Dr. Hassan. Thank you so much for your nice review and comments. Let's move to Aachen University Hospital, Dr. Adam Fatma. So, how do you look at it? So, I think what we have learned, my personal observation, and also from Dr. Hassan alike, like we have shortage of oncology competent clinical pharmacists. And how can I actually, when I came to Saudi Arabia, we had the same problem. So we started residency training program, PGY2 oncology residency training program, and I have trained more than 30 or 40 people. And now we have organization called SOPA, Saudi Oncology Pharmacy Assembly. With this platform, many other people actually are trained, and now we have a great team of oncology clinical pharmacists. And once upon a time, there used to be only one clinical pharmacist in the whole country, and now we have more than 100, maybe more than 200 leaders in oncology pharmacy. So how can we do this in Pakistan, Dr. Alam? I think this is the first step. We need to educate ourselves. We need to make ourselves competent, and then we can ask for empowerment, and we can talk to physician eye to eye contact, and then probably we can address so many issues. It's a long journey. But Dr. Adam Fatma, what's your take on that?
Assalamu alaikum, everybody. Thank you so much, Dr. Mansoor. It was such a nice presentation, very well explained everything. The take on this, whatever you said, it's we don't have sufficient knowledge of oncology in Pakistan. In the pharmacy setting, in the university setting, we don't teach people about the oncology so well. So the people are not aware about the oncology medications, the drug, the diseases. Once we enter in a hospital setting, we get to know about the oncology drugs. So in the starting, they don't have any knowledge about anything. So I would recommend if universities and education sectors start giving knowledge about such an important topic like oncology in the start, so that people can get aware of it at least. And the thing that you said, that we should start an oncology stewardship program, and we should have oncology uh, certifications and oncology students that can come and get taught about the oncology. I think that's such a great idea. In Pakistan, that what Dr. Hassan said, I really second him. He said everything very right. that we don't have sufficient staff, we don't have sufficient knowledge about oncology, we don't have sufficient drugs. And I think that that you have started the PGI program, that's such a good thing. If we start in Pakistan, that would improve the settings, oncology settings criteria in Pakistan as well. We can get sufficiently knowledge about that oncology medications. And in Pakistan, in our country, we have started an ASHP program, and we got certification, but we don't have any certification related to oncology, specifically oncology. As you said, you have started ASHP of, you have started oncology program that, uh, so I would like you to give some idea to us so that we can start the same program in Pakistan as well. So we get efficient knowledge about each and everything, and we can start this same thing over here.
Thanks, Dr. Anam. I think my personal take on that, universities are not going to play any significant role in providing oncology knowledge. If you
Mm-hmm.
go to US, Europe, you go to Middle East, UAE, so universities are not playing. I'm teaching in 3, 4 universities also. So, and I'm facing problem in teaching students in the foundry, in the curriculum. So we are giving them very basic knowledge in oncology, and they are quite happy and appreciating that. But that's so simple and basic. I think the hospital industry has to step in, and oncology pharmacy society has to step in, and I think giving back to pharmacy in Pakistan has to step in, and the experienced people and experienced leaders in the profession from wherever they are, Shokat Khanam, Mara Khan, Shifa, wherever they have to step in. The leadership of these institutions, they have to step in. And we have to start some kind of program. Believe me, if we are not competent about oncology, it's not only medication. We have to understand pharmacogenetics. We have to understand precision medicine. We have to understand therapeutic basis of oncology and hematology. We have to speak the same language which the physicians speak, and then believe me, we'll be able to talk to them eye to eye contact. And Dr. Hassan mentioned like the pharmaceutical industry is going to physician, hematology, oncology physicians, and we don't know what they're discussing. And actually, when I came to Saudi Arabia, it was the same thing here. Now, physicians and hematology physician, oncology physician, they're definitely meeting with the industry, but they have to go through us now because we are one of the most strongest stakeholder in the P&T and formulary management. So of course, they have influence on the practice of the physician, but we are one of the sensor that they have to go through us. We have to analyze their practice, and we are equal partner in choosing the regimens for our patients, whether it's formulary medication or it's non-formulary medication. And that simply happened because we equipped ourselves with the knowledge and competency, which is leveling with the physician, not at the diagnostic level, but at the therapeutic level. So we are able to speak to our colleagues, physician, hematology, oncology. And not only we have to step up in teaching not only oncology pharmacists, but also we have to play our role in educating nurses, our role in physician. We have to play our role in oncology fellowship programs. So we have to do a lot of things in educating ourselves, our colleagues, before I think we can talk about empowering ourselves. So I think we lack some basic things. As I said, it's a long journey. Dr. Siddiqui is here, so we need his support. We need the support of Giving Back to Pharmacy in Pakistan. So definitely with support of everyone, then we will be able to put ourselves on the track. So moving to Shifa International, Dr. Zishan Ahmed Khatak. So how can we address these challenges?
Assalamu alaikum, sir.
Walaikum salam.
So it was a great presentation. Actually, I will agree with Dr. Hassan that there's a monopoly of pharmaceuticals and medical reps in our country. Like it is very hard for biosimilars to get registered in Pakistan. Like when you talk about rituximab, Roche is offering buy one get one free, but same like when patient buy other biosimilars, Rituxim, it comes with the same cost. So there's a monopoly of pharmaceuticals, and we are dealing with daily shortage of life-saving medications. So we have to involve RAP. as outside pharmaceuticals like in Islamabad, pharmacies are keeping uh, many huge stock of doxorubicin and apirubicin, which is actually short in Pakistan and in Shifa, but they are storing it and they are offering their own price to patient. Like if doxorubicin price is 100 rupees or 1000, let's say 1000, they can convince a patient or its attendant to that we will give it to in 5000. So we have to involve DRAP and uh, so they can register some other products, uh, as it is very hard for me to treat patients in oncology with the very limited drugs and very expensive medications. Thank
So
you.
what do you think? How can we address this monopoly? You know, when I came to Saudi Arabia, I had the same kind of monopoly here. So how can we address this monopoly in Pakistan? So what is your take on that? Should we
So
invite, we ask
so
Grab,
DRAP has to step in. So DRAP has to step in.
Grab has to step in. So I think what we did, we talked to Saudi FDA, and Saudi
Mm.
FDA is a key player in regulating the drug prices. And then we have the National Unified Procurement Company, which is regulating the prices for the public sector. So we need to have a national procurement company in Pakistan, and the DRAP has to play a very significant role in regulating the drug prices. And at the same time, we need to empower ourselves. Before empowering, we need to educate ourselves. So last panelist is Dr. Sumaya from Indus Hospital. So what is your take, Dr. Sumaya, on that?
Thank you so much for excellent presentation, Dr. Mansoor. Yes, I agree. We are short of competent pharmacists. So we need to first educate ourselves, then we'll be able to implement this oncology stewardship. And it's very important for to make people understand what this oncology stewardship is. We have antimicrobial stewardship in front of it, so we can make it role model, and we can work on statistics to implement it. And we should collaborate with each other in order to implement this, because collaboration, teamwork, and consistency is the key for the implementation, I guess.
Definitely, definitely. Definitely. I think, Dr. Siddiqui, if you can allow us just a few minutes more, we need to conclude this session. So with this, actually, we.
Sir Mansoor, sorry to interrupt. May I add something?
Oh, yes, yes, I'm sorry, I'm sorry. Yes, please go ahead.
Thank you. Thank you very much, sir. From this platform, I am really very thankful that giving back to pharmacy highlighted such a crucial issue, which must be addressed in a country like Pakistan. So, on the behalf of this platform and utilizing this opportunity, I would suggest two to three things. That first, I would request you and Sir Siddiqui to kindly have sessions related to this, more sessions to be arranged in the coming time, so that we could come up with some solution. And secondly, what my thought is, as I 100% agree with you, that the leaders or the pharmacists who are working in highly reputable organizations like Shaukat Khanum, Al Khan, and Shifa Hospital, they must step forward. They must step forward. They come forward, and they took the lead in educating the other pharmacists who are working in remote areas, or who are involved in oncology practice, with any kind of oncology practice, whether they are working in a clinical setup or not. So this team should come forward, and they must took the responsibility that, if I say about myself, that Shaukat Khanam is readily available to educate the pharmacist who is working in any oncology setup. And if he or she wants, or if he or she needs some kind of training, like how we are working in that organization, so we are readily available. So I think other colleagues definitely think like so. So second thing is, we must have a list of pharmacists, or a rough list of pharmacists who are directly or indirectly involved in oncology pharmacy practices, so that we could have future plan for them, to educate them, to take them with us to participate in this novel objective. And third is we must have some collaborative work. We must have some research to show up with to the authorities that this kind of scary situation or the critical scenario Pakistan is suffering from. So we must highlight the situation to the entire world so that we could have some more opportunity from national and international level as well to implement this novel objective in our country. So thank you very much. This was my
Thank
speech.
thank
Thank
you,
you.
Dr. San. I think there is one question. There is one question Dr. Siddiqui sent me that somebody was asking about the resources, books for oncology. So I recommend the pharmacotherapy review for the board certification in oncology, and I encourage people to prepare for BCOP, which is board certification in oncology pharmacy. So I have 2022 pharmacotherapy review resources with me, so we can share with the group. And we have oncology group actually, and those who would like to join our WhatsApp oncology group from the Giving Back to Pharmacy in Pakistan, they can join there, and we can share uh, the BCOP reference material for 2022, which is quite helpful. And you can also review the material on NCCN guideline on each disease state. And then we have Dr. Maheen Faisal. She raised the hand. Quickly, if you can ask the question, please. Unmute yourself and you can ask a question, if Dr. Siddiqui allows.
Hello, Assalamu alaikum. Basically, I'm not doctor, but exactly the student. So, rather than question, I had some suggestion which I wanted to add. So, you talked about mainly two things, and in your presentation that were introduction of biosimilars in Pakistan, and the second thing was the statistical importance and the significance of the statistical data introduction, which can say about the cost effectiveness. So personally, I think that given the situation of Pakistan and the situation of the lack of resources, personally, I think it would be better that we start from the working on the statistical thing more. Like if we have the availability of A, B, and C drug already in the hospitals, we can work on the statistics and find the correlations and
Thank you, Mahim. Thank you. Thank you, Mahim. Thank you. Thank you for your suggestion. So I think we're running out of time, so we need to conclude now. So I have few suggestions as a conclusive remarks. Of course, we have to implement these 4 points, which is listed on the screen: cost-effective formulary management, and we have to play our due role, development of implementation of clinical practice guideline, MUEs, implementation of clinically meaningful outcomes, implementation of high quality generics and biosimilars in oncology practice. Definitely, this is all going to help in establishing oncology stewardship program. But before that, we need to educate ourselves. We need to educate our pharmacists, our oncology clinical pharmacists. We have to make ourselves oncology clinical pharmacy competent professional. And for that, I think we need more series of these kind of webinars. And I suggest that in our next webinar, we should bring the leadership from the hospitals. We have the panelists from, so we should bring the leadership from those hospitals, as well as if somebody can attend from the public sector as well. And I also have a suggestion to write a paper, because we need to create awareness of this program, and we have to include the general masses, the cancer patient, the general population as one of the key stakeholders in our program. Because if they are educated about cost effectiveness, if they are educated about financial toxicity, if they are educated about their disease, they can play a very significant role in cost of care discussion directly engaged with the oncology clinical pharmacist. So we can break, we don't want to break the bridge between patient and physician, but we can make it more cost effective channel, or we can make this bridge more cost effective between patients and their physicians. So for that reason, we have to use social media, print media, and electronic media. And I encourage that we should convert this presentation, this webinar, this discussion, how to address the challenges, into form of a paper, and we can publish this in a peer-reviewed journal, one of the Pakistani journal, which everybody is reading, like JPMA or any other journal, and I can sponsor the publication fee for that. So I think this is my suggestion. Any other suggestion or um, question, so we can close it within 1 minute. I think I asked for 5 minutes extra. That time is already over. Any other suggestions? So who is in favor of having a paper?
I think we must go with the paper, sir. We must have it.
And we need to have the next session. We need to invite the leadership from the hospital, like pharmacy directors. So we have to bring them here so that they can also understand the process, so we can have their support as well for our program. So maybe we can hear from them how they can support us. What do you think, Dr. Adam? And
I
Dr.
totally
Sumayya?
agree with you that we should invite our directors also.
Yeah, so they should come to this meeting, and we
Yeah,
give them quick overview, and then they can tell us, maybe they can have a better view how they can support us. Maybe they can talk to higher management so they can give us some kind of support, and we need that support to educate ourselves
definitely.
and empower ourselves. So we need to mention these kind of things in our paper. Okay, so we will continue our discussion sideline with our WhatsApp group in order to further intensify the discussion and collaboration. And this is just the beginning. This is just the foundation that we laid down today with the first brick by our Giving Back to Pharmacy platform and all our panelists. And I would like to thank Giving Back to Pharmacy Back to Pakistan. And I would like to thank our dear panelists and attendees for your presence. Thank you so much. And we would like to look forward to have your presence and attendance in future in order to have further collaboration, in order to achieve our goals. Inshallah, may Allah subhanahu wa ta'ala help us in achieving our goals. Thank you so much. Assalamu alaikum.